Hello, everyone, and welcome to our GE Healthcare Clinical Conversations webinar. Just a few housekeeping notes. For the best viewing experience, we recommend using a wired connection and closing any programs or browser sessions running in the background. Webinars are bandwidth intensive, so closing any unnecessary browsers or tabs will help to conserve your bandwidth. For the best audio quality, please make sure your computer speakers or headsets are turned on and the volume is up. Also, make sure your media player and your Adobe player are up to date. Some networks cause slides to advance more slowly than others. So if your slides are behind, just push the F5 button on your keyboard and it'll refresh your page. At the center or bottom of your screen, there are multiple application widgets you can use. All the widgets are sizable and movable, so feel free to move them around to get the most of your desktop space. Hover over the widget to see what its function is. There will be a short period of time available after the presentation for questions. If any come to mind during our segment of the presentation, please submit the question using the Q&A widget, and they'll be answered as time permits. If we do run out of time, we'll answer them later via email. After the Q&A period is over, you'll have 20 minutes to take the assessment quiz. The CE widget will be active once you have completed 45 minutes of viewing time. If you arrive later, your CEU may not be accessible if the time requirement is not met. You can access the quiz using the pencil widget found on your screen. You'll need to answer 6 out of 8 questions correctly to earn 1 CE credit. Upon completion of the test, you'll be able to print out your CE certificate by clicking the yellow certificate icon. Once again, participation time must be met for the CE widget to be activated. If you're not able to meet the full 45-minute time period, the webinar will be recorded and available on demand. You'll receive an email with a link to access the on-demand session when it's available. You'll have access to the test and the CE certificate there as well. Lastly, we would appreciate your feedback. So let us know what you thought about the webinar or if there are any future topics you'd like to see covered. The survey is a dark green icon at the bottom as well. Alrighty, so we're going to get started with our presentation. MR Introduction to Spectroscopy by Dr. Ralph Noeske. Thank you, Dr. Noeske.
Hello, everybody, and thank you for joining. I hope you can hear me good enough. So I want to give you today a quick introduction to MR spectroscopy. Spectroscopy is a broad topic, so having 45 minutes, I limit myself to give you, as in the title, an introduction into the mainly clinical use of MR spectroscopy. So I'm a senior scientist in the Applied Science Lab in GE Healthcare, so I'm developing, together with our collaborators, new technologies in the area of MR spectroscopy. And with that, I start moving forward. So the disclaimer, I think, we can quickly move over. So what is it about we are doing in MR spectroscopy that makes it also so different to MR imaging? So in principle, we are looking at spectra. So we can call it the virtual biopsy. So we are not just looking at images, but we are looking at chemical or at chemistry mainly in the brain, and I limit today myself also to brain, as this is the main area of MR spectroscopy, and at the metabolites we do have in the human brain. So, as I said, this is a classical spectrum we get, and within this spectrum we do have a lot of metabolites, so a lot of peaks, and we know to which kind of metabolite these peaks belong. So the major one at 2 ppm is N-acetyl aspartate as neuronal marker. We do have glutamate as a neurotransmitter, creatine as an energy marker. We do have also choline as a membrane marker. And finally, of the major 5, I'm concentrating today myoinositol as a glial marker. But you see that there are many more peaks in the spectrum that belong to other metabolites I'm not specifically mentioning today. It is quite difficult to more or less identify all the metabolites and all the peaks in a spectrum because of the amount of or the concentration of these metabolites in brain. So for clinical spectroscopies, these 5 are the major metabolites we are interested in, and they can tell us a lot about brain metabolism. So now coming back, what is so different in MR spectroscopy compared to imaging? So just consider this bottle of wine. In this example, a very old one of the most expensive ones from the 18th century, a Lafite. And what happens if we are putting this bottle of wine in a scanner and make an image out of it? We just get an image of a liquid, so we don't know exactly, is it water inside, is it now wine, or if we just have vinegar because the bottle got broken. So is it really that much worth that some people paid for it? Spectroscopy can answer a little bit more than just imaging for this bottle of wine. So consider an experiment where we acquire in the brain a spectrum in a normal control. This is on the top here. Very similar looks like the spectra I showed in the previous slides with major peaks. You are hopefully now a little bit more familiar. So now we are looking into the bottle, so put the bottle of wine into the scanner and then do also a spectrum of it. And then we get a typical spectrum of alcohol. And here, this is mainly ethanol, a triplet at this position, 1.3 ppm, and a quadruplet at 3.7 ppm. So this is a typical spectrum we get from alcohol if we put it into the scanner. And then if we let the participant drink this bottle of wine and then put him into the scanner, at first the volunteer is drunken, but that's not the problem here. So we acquire again a spectrum, and then we see a spectrum that is really the composition of the normal spectrum before he drank the bottle of wine and the alcohol. So we can clearly identify the peak of ethanol in the brain now, and also here it's just overlaid. So this peak is not overlaid by other, so we can identify the alcohol. And that makes it really different to imaging. But in principle, we are not interested in identifying alcohol. I think that would be much too expensive if we take spectroscopy as a test of how much the people drank. We want to look at normal brain and also at diseases, how the spectra look like for specific diseases. And for that, as I mentioned, we look at specific metabolites in the brain. And now I'm going through the list of the main metabolites you will see in a typical spectrum from the brain. And I start from right to left as it goes from 0 to 4.7 ppm. And starting from right, I start with lipids. So lipids are the main lipid peaks here in a normal spectrum, not seen, but they are at 0.9 and 1.3 ppm. Lipids are the fatty acids we do have in our brain, and it can be indicative of tissue damage in different diseases. The only thing you need to be careful about is that you find lipids, or a lot of lipids, within the scalp fat. So you don't want to have that, so you need to be careful not to get too close to the skull when you do your spectroscopy. So where do we see lipids if they are not usually in the standard spectrum of a healthy control? So we do see lipids in a lot of brain injuries. Here an example of a non-accidental brain injury. So the brain progresses through that injury the lipase cascade that causes the lipids to increase. So you see from day 1 to day 3 and 5, the 2 lipid peaks increase. We do see also lipids in tumors as a sign of necrosis. So lipids can be useful information in some injuries, and some lipids, like the skull fat, as it is a huge signal we want to avoid. So the next to the left, or nearly at the same place as lipids, and therefore also overlays with lipid signal, is lactate. Again, in the healthy control spectrum, we usually don't have lactate, but here at 1.3 ppm, we would have a lactate signal. So lactate is a hypoxic marker. So it's an end product of the anaerobic glycolysis. So in case the brain is not getting enough oxygen, it uses this process to get energy to the brain, and in that process, lactate is an end product. So we can say that lactate is a hypoxic marker, and therefore we see increased lactate or lactate at all in hypoxia. It is also, or it can also be used as a prognostic marker, as it is indicative of the severity of an injury. Here an example. The example is I'm currently a little confused. I thought I do have this example already in the next slide, but I will show that much later. An example where we can see lactate as a prognostic marker. So the most dominant signal in our spectrum is usually an acetyl aspartate, and they are the strong singlet at 2 ppm. There are other peaks that belong to NAA, but the 2 ppm peak is the most dominant one, and NAA is a neuronal marker. So it's, as I said, the most popular marker because it's the largest peak, and it represents the amount of neurons you have in the brain. So NAA is produced in the neurons and transported on axons, so the concentration you can find in brain is proportional to the functional neurons that you can find in that brain region and that you are measuring. And this really becomes important as it gives clinicians, particular neurologists, insight exactly in what is going on inside the brain. How many brain cellular function is really important. How many cellular neurons are really functioning. It's more or less represented by the height of the peak of NAA. We see NAA changes in a lot of diseases. For example, in focal lesions where neurons, there's a loss of neurons. The same in tumors where NAA drops, dementia and other neurodegenerative diseases, NAA drops, and also other brain injuries where the tissue is damaged, this NAA peak drops. So we see here also NAA can be used as a prognostic marker about the outcome of a brain injury. So if there is only a low amount of NAA loss compared to control, there will be a good outcome. The more severe this loss is, the worse the outcome is. And this example, again, is really from patients with different severity of brain injury. And we really can say if there is 20% or approximately a 20% of NAA loss, which you would think of is not good if you lose something about 20% of your neurons. But even then, there is a good prognosis for recovery. But those who lose more than or about 50% of their neurons, there is unfortunately not a good prognosis for the outcome. So another marker is glutamate and glutamine. It's left of the big NAA peak at around 2.4 ppm. So glutamate is an excitatory neurotransmitter, while glutamine is a marker of ammonia metabolism. Generally, or in a lot of publications, you find the acronym GLX as a combination of glutamate and glutamine, as both spectral patterns are really overlaying, and it is hard to separate them at 3 ppm. Therefore, these peaks left of NAA are usually marked by GLX, and meaning it's both glutamate and glutamine, even though they have totally different function. So, as I said, glutamate is a neurotransmitter, and therefore it is very interested for a lot of neuropsychiatric diseases. You can also see changes in glutamate as a result of Alzheimer's disease. It drops in these cases. And therefore, it is also an interesting marker for clinicians. Glutamine, as I said, has a different role. The glutamine cycle is a cycle by which ammonia is processed within the brain. And with that, in cases where we have that's a difficult word for me to pronounce all the time. I always struggle there. This hyperammonemia, I apologize for that. In that case, we do have a lot of ammonia production, and therefore glutamine increases by sometimes some factors. So you really see an increase in that signal in these diseases. Another neurotransmitter I just want to mention, even though it is not really playing a big role in clinical spectroscopy rather than in a lot of clinical research study, as it is also a neurotransmitter, the same as glutamate, but it's an inhibitory neurotransmitter. So it's really drops in several diseases, mainly interesting in psychiatric diseases. But as I said, it's not a metabolite that is currently used for individual diagnosis. It's more in the realm of clinical research. You need specific dedicated sequences to analyze it. And currently most studies involving GABA are on the level of group differences, so no individuals. I just want to mention it, and if there are questions later, as it is, as I said, very popular in the moment to measure GABA, I can also give them a little bit more information. But for the moment, this is not one of the major metabolites that is interesting to the clinical use of MR spectroscopy. So the next marker, the next big marker is creatine at about 3 ppm. It's fairly stable concentration within the brain. It is an energy marker, so it is part of the whole phosphocreatine ADP ATP metabolism within the mitochondria. And as I said, it's pretty well preserved, and therefore we use it typically for normalization as part of ratios. So you might see NAA over creatine ratio or choline over creatine ratios given in a lot of reports or publications rather than other measures for the individual peaks. So choline, the next one is very close to creatine at 3.2 ppm. We see choline as a membrane marker, and therefore choline increases with the increase in membrane density. So if you look at gray matter versus white matter, we see a bit more choline in white matter as there is a higher membrane density. Pathologically, where we have damage to the membrane, choline becomes released to the fluid, and then we see an increased choline in the spectrum. For example, here where the choline is clearly larger than the creatine compared to our standard normal spectrum, we immediately see the difference. So we see an increased choline signal in brain tumors like here, but there are also other tumor markers that we have today or that become more popular for specific tumors. But we see also an increase in choline in multiple sclerosis. So now coming to the last of the big 5 markers I want to mention today, that's myoinositol, and this is a glial marker. So the biggest peak is at 3.6 ppm, and very similar to NAA as a neuronal marker, myoinositol is a glial marker. It is produced in the glial cells rather than the neuronal cells. And we see an increase in a number of diseases, like in Alzheimer's disease or in Down syndrome, where we see an increase. But we sometimes also see a decrease, for example, in hyperammonemia. I will learn it once in my life, hopefully. But it is not just a glial marker. It's also a marker for other processes in the brain, as it is a sugar that is metabolized in a number of different diseases and also an osmolyte. We see reasons for a decrease in myoinositol other than it's a typical glial marker. Why I said this, in the Alzheimer's disease, it's most likely that we see an increase in the myoinositol due to the glial aspects to it. So now coming to the question, how do we know what is normal? Because we need to understand when we see a spectrum from a disease area, is there something different? What does that mean? And for that, we look at the typical spectrum, and I learned also spectroscopy or the clinical use of spectroscopy during some courses at Huntington Medical Research Institute a longer time ago, when Brian Ross gave these courses, and even earlier than I started doing spectroscopy, people also ask, what is normal? And at that time, at this institution, they came up with the name of Hunter's angle, because one neurologist asked, what is a normal spectrum, or how can you explain what is normal? And when scientists started to say a normal spectrum if the NAA level, NAA to creatine ratio is something about 1 point something, he said, oh, no, that's far too difficult. And he's true, or at least in most clinical applications where we can diagnose based on the pattern we are seeing, so on just by looking at a spectrum and not really quantifying it and looking at numbers, there's really a way to say this is a normal spectrum, or this is how a spectrum should look like, and therefore if I see other patterns, I can already give a diagnosis without using fancy quantification techniques that give you at the end numbers of concentration of metabolites. And they came up with this terminology, Hunter's angle, as at that time this neurologist put out his pocket comp, at least that was a long time ago, a normal thing people carried with them, and just hold it to that spectrum and came up, no, if these peaks are in an angle of 45 degrees, that looks to me like a normal spectrum. And to be honest, this is some kind of quick and dirty way of knowing what is normal, but there are some caveats, obviously, with that. And these caveats are that this 45-degree angle, at first, it's just for short echo time spectra, so it's not for all spectra that you see depending on the protocol. It is age-dependent, so we know that in children it is nearly inverse. So because children start with a low NAA, and when they grow older, the NAA gets higher, and also starts with a higher choline and myoinositol. And we know it is region-dependent. So there are some regions where the choline is a little higher. So I already pointed out the differences between gray and white matter. So, but with all this information about how a normal spectrum looks like, what these peaks mean in terms of what metabolites they represent, how can we use that at the end for diagnostic, for a diagnosis? And what kind of protocols can we use for understanding different diseases? In principle, there are two different kinds of spectroscopy we can do. One is called, or one can be called global, and global means in this definition it's a disease that affects either the whole or a specific region of the brain. And there's a list of diseases that we can more or less call a global disease. And again, it doesn't mean that the whole brain is affected, but it means that it is not specific to an individuum where this disease is more or less taking effect. And in contrast to that global are the focal diseases, and these diseases affect non-specific regions of the brain. So like brain tumor, abscesses, lesions, and stroke. And obviously these locations, and that's the reason why we call it focal, they differ in place and size from individuum to individuum. So it's really two different ways you address the diseases and you're doing the spectroscopy. And often I think the focal spectroscopy is the one thing that is done most, but is also the more difficult one. Because in the focal spectroscopy, you need to think about where to place the voxel, how big should the voxel be, how many acquisitions do I need to do to get a good quality. Whereas in the global spectroscopy, with these, you can already address a different amount, a large number of diseases where it's easy to place the voxel because in each of the diseases you know your voxel location and how big the voxel needs to be to get high quality. So it's a simple acquisition that can be done. So placing your voxel, starting the acquisition, and after a few minutes you have a good spectrum of good quality and you can already give a diagnosis. So in that sense, the global diseases are easier to address and start with, while the focal diseases are the more obvious and common ones when people think about spectroscopy. So starting with the global diseases or the global spectroscopy, what is a typical gray matter voxel? So for that, it's the occipital gray matter or posterior cingulate gyrus. So here in the posterior part, really covering in a voxel nearly all gray matter. And why is this voxel selected, or why people started when they wanted to look at a gray matter voxel with this location? And this has nothing to do in the first place with the function of the brain region there. It's more or less, it's more for convenience because it's an easy place to get a good spectrum because of two reasons. It is very homogeneous in that area, and if you think of patient motion, and in the beginning, when we are even going back to 1.5 Tesla spectroscopy, where acquisition times were longer than today, there were an even higher chance that the patient moves the head. And if you really think of head motion, then it's more from right to left. So it's easier. And if you then look at what places more or less stay at the same place, then it is this posterior part. So therefore, the posterior part is very easy to place the voxel and get very stable results. And therefore, it is one of the most reproducible regions in the brain. You should stick to a standard protocol and always keep that protocol so that you can really compare it in between sessions of that patient or in between patients. So therefore, one of the today most common protocols is a short echo time, 30 millisecond acquisition with a repetition time that is not too short to get T1 weighting, too much T1 weighting, not too long to make the acquisition, the overall acquisition too long. So it's an intermediate repetition time of about 2 seconds, and a typical voxel size of 2 by 2 by 2 cubic centimeter, so an 8 milliliter voxel. And you really should place that voxel and look in all three localizer orientations, that you make sure that it is really in the gray matter, that you don't get too close to the skull, and for example, for the gray matter, that you don't get too close to the corpus callosum or get into it. So again, where do we use this diagnosis with this posterior singular gyrus voxel, it's in Alzheimer's disease or in metabolic disorders. And here we do have 4 different spectra. On top again, what we call the normal. And on the bottom, you see for 3 different diseases, for Alzheimer's disease, for hypoxia, and I need to think about what encephalopathy this is, for hepatic encephalopathy. So for 3 different diseases, and you clearly see that there are differences in the pattern of these 3 diseases. So you have an increased myoinositol in the Alzheimer's disease. You have a decrease in NAA, in hypoxia, beside the appearance of a lactate signal. And therefore, already by so-called pattern recognition, by really looking at the pattern of the spectra, you can distinguish between different diseases, or you can confirm different diseases. You need to always take into account that spectroscopy is never done alone, so you will always have the history of the patient, you always have the imaging, so it adds extra information. So it's not like you're putting a patient in and you don't know exactly what to expect. So for that, even though, for example, the decrease of NAA is not very specific to a single disease, with all the other information you have already about your patient, you can better give a better diagnosis when you take or add spectroscopy. So the lack of specificity for some metabolites, again, we know that the metabolites decrease or increase, the different ones in different diseases, but this lack of specificity is not really a problem with all the information you have in addition about your patient. So here again, the case of you have seen before, also acquired in that voxel position of the coma status and of different people. And already from the NAA level, as I pointed out earlier, you can really give a prognosis about the outcome for this patient. So what is a typical white matter voxel? It's the parietal white matter here. Also, please look at all 3 locations as that you don't get too close to skull or other structures. So you can access with a white matter voxel axonal conditions and metabolic disorders. So in global diseases where you want to have additional information about that, you place your voxel in the white matter, and this one is a good location. You have the same protocol as with your gray matter voxel, as you really want to compare all your spectra. So keep in mind, stay consistent with your protocol. There are other brain regions that become popular in the literature. So one is the anterior cingulate, which is very similar to the posterior cingulate, except that it is slightly elongated to capture much of the cingulate. And it is, of course, placed in the frontal part of the brain. It's slightly rotated. You have to be very careful that you are not too close to the skull. And because it's very close to the sinuses, you get some susceptibility effects, and therefore your quality of the spectra is sometimes, it's sometimes more difficult to get a good quality spectrum in this area, so it's a more challenging area. It's interesting in a lot of psychiatric disorders, so that's the reason why people are interested in. So it's more used in clinical studies, therefore. As I mentioned before, psychiatric disorders, it's more on the group level that we today analyze our spectra. Another global disease is looking at mesial temporal epilepsy, and there we look at the hippocampus and place the voxel left on the right side to see if the NAA level goes down in one of the sides, and where there is lower NAA, this is more likely to be the location of the seizure focus, and therefore it's helpful information for the neurosurgeon. Other interesting locations, very tough to see here, it's the basal ganglia. It's a little smaller voxel to be sure that you are just getting signal from the basal ganglia, and as there might be sometimes hemorrhage in, it's more difficult to shim in that region. But there are various fixed positions in global disease that don't differ from patient to patient, so it's very easy to get reproducible positions and reproducible results. So there is recently, or it's already 4 years ago, a publication in radiology about the clinical use of spectroscopy, and this is a consensus paper, so a consensus of all the spectroscopists from the ISMR study group concentrating on brain disorders. And this is really a very, very good reference for everybody doing clinical spectroscopy with recommendations where it is useful or where has a spectroscopy shown and proven usefulness and where it might help. So it really lists a lot of application areas, and together with how the protocol should look like. It's in this presentation most probably too small, but you really should write down this reference and look into this paper, and also lists the metabolite that is important for this application. So it's really a great reference, and it's the first kind of paper that this consensus group tries to bring out to push again the clinical use of spectroscopy. As I said, that focused on clinical spectroscopy in the brain. There will be follow-up publications in the future that more concentrate on the techniques that should be used in the future or today that are available or should be made available by the vendors to the communities, and or how you should process your data. So just follow up how the field will bring out these consensus papers to help you to use this technique. I really want to come back about the importance of consistency in your protocol. So here's an example of a child with adrenoleukodystrophy with no symptoms, so asymptotic. So it's also a longer time ago that this data was acquired, and at that time the Lorenzo oil was a controversy treatment. So there was an agreement with the parents to do the spectroscopy and follow up and see if there are any changes in the brain metabolism. And only if there are changes, then they wanted to stop the therapy and go for bone marrow transplant, which in itself carries a high risk. So therefore, they started acquiring spectra over a period from 5.8 years age to about 6 years later, 11.8 years. And even with various scanner upgrades in between and really a huge number of different technologists acquiring this data, you can see that the data is really highly consistent. And this patient could stay on the Lorenzo therapy and as an adult is doing great. So this is another great example of how spectroscopy can be used for treatment monitoring and how consistent your results can be if you are really staying on a protocol and not changing anything during these years. So now looking at focal diseases, you can also speak of some kind of keyhole technique. You look through the keyhole into small voxels and see what is going on in the brain. So it's really in the size and location, it depends about the clinical question. So that differs to the global spectroscopy, where you could always put your voxel in the same location, same voxel size. Here it really depends on the clinical question and the previous history. And the goal is to optimize for homogeneity and shim as well as SNR. So there are two things we need to focus when we are looking at focal spectroscopy. So here's an example, a case of a highly heterogeneous region where we place the voxel. And there's a lot of blood within this tumor, and so the spectrum we get is really, if you look at that, even without much knowledge, just keep in mind how a normal spectrum should look like. It's far off, and therefore that's garbage. So you really should avoid heterogeneous areas like the getting too close to skull, to avoid lipid contamination, to avoid necrosis, because that can also give you lipid contamination, areas with high blood because of the ferrous components, you get a poor shim, and so the spectral quality is really, really bad. And you should also be careful getting too close to open spaces, because that's also increasing your line width because of higher inhomogeneities. Ventricles, you should avoid full CSF contamination, but enough people showed that just having 10 to 20% CSF in your voxel is not really an issue. It's an issue if you start doing quantification, and then people need to take that into account. But as long as you just want to have a high-quality spectrum for diagnosis, I think ventricles is not really the biggest issue, as long as I said, you limit the amount of CSF contamination in the voxel. So here's an example when you get too close to the sides of the brain, so to the skull, you get a lot of lipid contamination here, two huge peaks. And remember, I started with lipids at the 0.9 and 1.3 ppm. These are the lipids, and it's really difficult to analyze. Even though you see the metabolites, you can't really use this spectrum for either by pattern recognition, see the ratios, or quantification also has a problem. So please avoid being too close to the skull. There are some ways to then move the voxel slightly away from the skull. I show you an example. On some scanners, scanner platforms, you could also invert what we call the chemical shift displacement direction. I don't want to go into too much detail about that. If you have a scanner from a vendor that has this option, you could invert it, and and then get a little closer to skull. On the GE platform, we don't have that option that easily. It's more on the research platform where it works. So for that, the way to avoid to place, for example, if we do have a tumor that is often very close to the skull, and you would like to place your standard voxel on top of that, and then you get a spectrum. A spectrum like that where you have huge lipid contamination. So instead of doing that, you should move your voxel slightly away from the skull, avoiding lipid contamination here. Then we get what we call the partial volume effect. So only a partial volume of the structure you want to look at is within the voxel. So therefore, you get also signal from outside your lesion seen here. For example, we would expect a tumor lower NAA, so this NAA signal is more or less coming from outside, but the higher choline signal is an indicator for the tumor. So mentioning that, so in the focal diseases, size of the voxel does matter. Large voxel have the advantage you get high signal, so higher SNR, better quality, but you have a smaller partial volume. So the structure you're interested in is only a part of your signal. Smaller voxels, definitely the pro is your greater partial volume, but you have less SNR. And therefore, you need to balance these parameters, and that is sometimes a little difficult. You need to take into account that decreasing the volume, if you decrease the volume, you need to increase the number of averages to get the same quality of a spectrum. And unfortunately, that goes with a square. So that means if you reduce your voxel size by 50% or go to half of your voxel size or volume, it's not really that you half the length in each direction. If you really go to the half of the volume, you need to increase your acquisition by 4 times, and therefore making out of a 5-minute scan a 20-minute scan, which is unrealistic to be part of a clinical exam. Decreasing the voxel size definitely decreases the partial volume effect, or better, increases the partial volume, but as I said, it decreases the quality of your spectra. A way around that is using chemical shift imaging, and this is just an introduction into spectroscopy. I wanted to more focus on the metabolites and some applications. So easy to start with is single voxel spectroscopy, as it is easier to get good quality. So a way around having these partial volume effects is using chemical shift imaging. So also in spectroscopy, you can acquire data where you get spectroscopic information over a larger region, and we call that chemical shift imaging or spectroscopic imaging. So you get a grid of spectra, and unfortunately, I missed to put that on the mouse button, so we can't see now the color maps underneath, but believe me, there is a tumor here where we see lower NAA over creatine in that region and higher choline over creatine. But also the size of the individual voxels that are used to create these color maps is limited to get enough signal to really produce these color maps. So also there you're currently realistically limited to a 1 milliliter voxel size. Another case of a tumor patient pre-radiation therapy, and in the interest of time I move forward. So there are guidelines for these MRS acquisitions, especially these focal diseases, and I suggest you're looking at the paper from Alex Lin. He's really a long-time collaborator of us. We do spectroscopy training classes with him since a long, long time, dating back to HMRI times, and most of the talk here I also borrowed from him, as he's a very good clinical spectroscopy user, currently in Boston. So really have a look at these guidelines in this paper. So really concentrating again on the voxel positioning, the problems you can run into, that voxel sizes matters, so not going below this in most of the time, and shimming. And with that, it's also the quality control that you can do for yourself, and there is also a very good publication done by Roland Kreis a longer time ago, where he is looking into what does a good spectrum, or how does a good spectrum look like, looking at reproducibility of the results. If we are looking into quantification, how does SNR has an effect on it? We would call all these three spectra as good enough spectra for visual diagnosis. If we are looking at the end into quantification, we see that the lower the SNR, the less reproducible the results of our quantification are. The same with the spectral line width. If your shim is bad, here really a good example of a bad shim where creatine and choline start to merge, where your NIA signal gets broader and gets down. So these are really hard to use for diagnosis. So these are definitely two measures that you can use to determine the quality of your spectra. In the same publication, there are plenty of artifacts. So a full list of artifacts, a gallery of artifacts, how, for example, patient motion can end up in multiple peaks that are not really there. Modern post-processing can get rid of it if the acquisition is already adapted to allow that in post-processing. Lipid contamination, it's really, we see here lipid contamination. Do we know if this signal has an effect on the NAA? So that's the reason why if we see negative bumps next to NAA, we should be careful. And we can even have severe hardware problems or sequence problems and get high ghosts. So these are all artifacts you should get familiar with to be more confident that what you see in your spectrum is real signal and not an artifact. And for that, we don't have like an imaging in a 2D image where artifacts might be better separated from the area that you're interested in. In spectroscopy, it's one-dimensional data, so it's sometimes a little tougher to separate an artifact from real data. So just mentioning at the end that it is important that you know what protocol you should use and for what diseases you can use either global or focal protocol, and again, stay consistent with your protocol and acquire good data. But at the end, you want to process the data. And visual inspection is good for, or visual diagnosis based on the spectra is good for most or a lot of the diseases that I mentioned. Nevertheless, people are